The title of today's lecture is Restoration in Occupation. And no matter how meaningful, exciting, or complicated activities that we participate in are, at some point we all engage regularly in the mundane survival activities that restore our energy. Without adequate restoration, productivity and pleasure would also be low. Sleep is one of the primary occupation that goes along with restoration, and it's also the strongest argument, the one in which the strongest argument for the tie between occupation and health can be made. Patterns and habits of the sleep-wake cycle is very important to pay attention to, and without the restful occupation of sleep, humans experience broadly diminished capacities and loss of the ability to engage in satisfying occupations. Your immune system is more active when you're awake. So every day of inadequate sleep degrades your immune function and reduces cognitive capacities, making the person more lethargic, depressed, woozy, and slow thinking, and eventually succumbing to the assaults of various bacteria and viruses. So let's take a little bit of time and look at sleep. There's a difference between infants and adults in how they sleep. Newborns require, up until about 8 months of age, they require at least 16 hours per day on average. And then as children after 8 months of age and through childhood, they progress to needing a little bit less sleep, maybe 10 to 12 hours a day. The behavior of children who don't get enough sleep looks much different than that of an adult. They're usually very hyperactive, fidgeting, have difficulty paying attention, staying still. They're very emotional, impulsive, and aggressive. Whereas adults probably just going to be very lethargic. They may have difficulty paying attention too, but they're just groggy and not with it. The next group, if you're looking at a developmental progression, are teenagers, and teenagers are chronically sleep deprived. And part of this, I think, has to do with there's changes in the body, physiological changes in the body, and hormones will impact, I think, sleep. But I think it's also just behaviorally, it's the first time that the child or the teenager is learning how to manage time. And so now they maybe don't have a strict requirement of going to bed at 8 or 9 o'clock at night. And so they'll push the limits and stay up till wee hours of the night, and then they want to sleep till 2 o'clock in the afternoon. Then the next category, the big category of in terms of developmental progression, is the older adult, and they have numerous sleep problems with older adult. A lot of times this has to do with other medical conditions. They may have respiratory disorders, cardiovascular, GI issues, chronic pain, that type of thing that's going to keep them up at night. The medications they're on, a lot of medications have side effects that prevent an individual from sleeping well. They may be living in a very disruptive environment. They've gone to an assisted living or a nursing home type facility. They may have a roommate that they didn't have before, and it's just people coming in and out, walking in the hall. That may be challenging for effective sleep patterns. A lot of times depression and anxiety are present in the older adult just due to normal life changes, such as a spouse dying, or even the children moving out of the home, and then later on maybe the children don't even live in the same city, or they've lost contact with them. Those types of things, or retirement would be another example, I think, might lend itself to an individual becoming depressed or anxious. In addition to sleep problems associated with different stages of development, there are some specific sleep disorders that individuals may have. One is sleep apnea. It is a sleep disorder characterized by pauses in breathing or instances of shallow or infrequent breathing during sleep. Each pause in breathing, called apnea, can last for several seconds to several minutes, and it might occur, by definition, at least 5 times an hour. As a result, the person may snore, that might be a common as they're trying to catch their breath, or during the day, these individuals are usually very fatigued, may have difficulty focusing on what their daily activities. Sleep apnea is frequently treated with a CPAP machine, which can then it's a negative pressure. The individual wears a mask, and this helps keep a consistent breathing pattern. Another example of a sleep disorder is circadian disorders. People with circadian rhythm sleep disorders are unable to sleep and wake at times required for normal work, school, and social needs. They're generally able to get enough sleep if allowed to sleep and wake at the times their body that are dictated by their own body clocks. But unless they have another sleep disorder, the quality of their sleep is usually normal. Humans, like most living organisms, have biological rhythms known as circadian rhythms or body clocks, which are controlled by a biological clock and work on a daily time scale. These affect body temperature, alertness, appetite, hormone secretion, etc., as well as sleep timing. Due to the circadian clock, sleepiness does not continuously increase as time passes. A person's desire and ability to fall asleep is influenced by both the length of time since the person woke from inadequate sleep and by internal circadian rhythms. Thus, the body is ready for sleep and for wakefulness at different times of the day. Sometimes it's environmental issues that can cause a disturbance in circadian rhythm. If you've ever flown on an airplane and changed time zones and you've experienced jet lag, you've probably experienced a disruption in your circadian rhythm. Individuals who do shift work get their sleep-wake cycles all mixed up. Nurses, maybe workers in a factory, police officers, or some examples of occupations that may have shift work. You might be on days one week, nights the next week, or it may be even within the same week. People who have problems with controlling their temperature, they may have hot flashes that wakes them up, or maybe circulation issues that makes it, even with lots of blankets and covers and things, it makes it very difficult to sleep. Or they may have some other illness that causes them to have difficulty with their temperature regulation, which would then affect sleeping problems. And like I mentioned before, with the older adult, there are lots of medications that people take that may have side effects, which would cause a person to require more sleep or disrupt their sleep. And then the last sleep disorder condition is called, that I have listed here, is called narcolepsy. And narcolepsy is a chronic brain disorder that involves poor control of sleep-wake cycles. People with narcolepsy experience periods of extreme daytime sleepiness and sudden, irresistible bouts of sleep that can strike at any time. These sleep attacks usually last a few seconds or possibly several minutes. Narcolepsy can greatly affect an individual's daily activities, as you might imagine. People may unwillingly fall asleep when they're working, or they're at school, when they're having a conversation, playing a game, eating a meal, or more dangerously when driving or operating other types of machinery. So therefore, they frequently have a restriction that they can't drive or perform those kinds of activities, because what happens is that they experience total paralysis just before falling asleep or just after waking up. Okay, the next category of restoration, and obviously sleep is probably the biggest area, but another big one is restoration that we get from self-care activities. Really, self-care is the foundation. If you can't take care of yourself, most likely you're not going to be able to perform other kinds of occupations. And think about how it would feel to have to not be able to wash your face, wash your hair, brush your teeth, or if you've had extended periods of time where you didn't have access to that. Maybe you were traveling long distance, maybe you're camping, or maybe you've been in the hospital for an extended period of time and you can't assume your normal regular schedule. Getting that, I can remember being in the hospital even after having my own children, and one of the biggest things I wanted to do afterwards was take a shower and wash my hair, and I just felt so much better after I had was successful at taking a shower. So we have our 9 different categories of BADLs. So you have bathing and showering, toileting and toilet hygiene, dressing, swallowing and eating, feeding, functional mobility, personal device care, personal hygiene and grooming, and sexual activities. It wouldn't be a PowerPoint without a couple cat pictures. They too need to take care of those. They're very good at self-grooming. We're going to talk a little bit about the acquisition of ADL skills and how children learn to perform their ADL tasks. And one of the things that is, although you would see developmental ages about when a child learns how to dress themselves or feed themselves or take care or begin their brushing their teeth or showering. It's also pretty much dictated by the culture and socially appropriate ways within their own family and community. So there's a little bit of wiggle room in terms of when an individual learns the skills, because part of it's going to be dependent on when it's introduced or when it's reinforced. That's why say for example, potty training. There might be some children that are quite capable of potty training at 18 months of age, and the parents are really pushing for that. And then there may be other children who could have potty trained much earlier, but they're 3.5 before they get completely potty trained, because it's just a lot easier to not have to fuss with. And until the child's really, really ready and pushing for it, the parents are real laid back and they just let the child wear a diaper. Or the explanation for how it is ADLs are culturally and socially defined. But with that being said, there is a progression. For example, children first learn how to undress themselves. It's an easier motor task than dressing, or before they're able to do fasteners. Being able to perform ADL tasks allows children to participate in other occupations such as education, play, leisure, social participation, IADLs, and later work. When children assume responsibility for ADL tasks, the caregivers are not required to do as much for the child. This increased independence contributes to the child's feelings of self-efficacy. By the time the child enters school, around 5 or 6 years of age, they're expected to perform all the basic toileting, grooming, and personal hygiene, feeding, and dressing tasks needed for school. Absent or delayed ADL skills may impact children's social participation in other occupations within their home, schools, community, and later work environments. For example, if a child can't dress himself, or he may have difficulty in getting ready for recess if they have to put a jacket on to go outside, changing clothes, getting ready for gym class, or even being able to manage their own clothing during toileting. There are a number of factors that can affect performance in children. First is just age. Children typically develop self-care and IADL skills in a sequence, achieving specific skills as overall competency increases, like I said before. And age is going to help determine when it's time to start and stop an activity. So there are different developmental scales that you can look at to determine when it would be appropriate to introduce education for the child for ADL. Training, if you will, with children who have a disability, or their disability status may impact their performance. For example, whether the disability is chronic, which means it's lifelong, like a child who has cerebral palsy. We know that they're going to have motor problems that are going to prevent them from acquiring ADL skills in a typical fashion, versus maybe a disability that's a temporary or an acute disability, such as having a broken arm or a leg. That will be a short period of time that the child might only have one hand to perform. The number of members in a family, the family expectations, the roles and routines influence the child's development of self-care and IADLs. Large families, geographical location of whether or not they live in the city or they live on a farm, personal characteristics of the family, members' coping skills, flexibility, parents' health status, grandparents' involvement are all going to impact the performance of a child. For example, let's just take number of children in a family. If there's several children in the family, most likely The older children are going to be pushed, especially if they're born one right after. You got one that's 6, 5, 4, 3. The 6 and 5-year-old are going to be expected to form their ADL skills and IADL of helping around the home much quicker because there's so many children in the family. Peers can have both a positive or a negative effect. Sometimes peers can be very supportive and nurturing, especially if a child learns differently than other children. But then sometimes children can be very cruel to one another, and so the child may become teased or bullied because they have difficulty performing those tasks, and that obviously is going to impact their ability to perform. Culture, environment, the benefits, customs, activity patterns. I've worked with children who, I remember one time I had a child that I worked with, and the parents were from Germany. Well, the mother was from Germany. They were stationed at the Air Force Base here. Father was an American. Breastfed her child until she was 7 years of age. And, that's kind of unusual for the American culture to breastfeed that long. But she did her typical child as well as her atypical child. It's just that her impacted a lot of her other developmental tasks, or trying to get independence and a lot of other things, because she was still child was still being breastfed. And then the physical environment. Certainly how much space a child has to move around in, lighting, noise level, visual stimulation. If you have a child who has sensory processing difficulty and there's too much visual stimulation, that's going to affect they can't pay attention to what they need to do to learn a new task. In many tasks that we're first learning, we want to determine performance, and we evaluate a client to determine their ability to perform ADL skills. We want to use both a top-down approach, which you remember is looking at the big picture, and a bottom-up approach, which looks at specific performance components. So in the top-down approach, what you would do is gather information through an occupational history. You'll be interviewing the client, and you're developing their occupational profile to determine what is important, and what their interests and what their strengths and limitations are. The bottom-up approach focuses on identifying problems in specific performance components. This approach may fail to identify how the performance component deficits affects the client's occupational performance, and that's why you want to do the combination of both the top-down and the bottom-up. So the bottom-up is going to look at specific things like what kind of strength do they have, what range of motion limitations they may have, is there any cognition, endurance, manipulation, visual perception, eye-hand coordination. A skilled clinician is going to blend the two in practice. Once a functional deficit is identified, the performance component deficit that causes the functional limitation is identified. The therapist then determines if it's possible to improve or provide remediation for the performance component, or if a compensatory strategy is needed to improve. This is just a list of a few. There are many, many more pediatric ADL measures, and I've got another slide that looks at adults. But the reason I listed the Battelle, or the BDI-2, is that this is a tool that is used in Louisiana in the early intervention program that's called Early Steps. And this is a very comprehensive tool that looks at all the domains in development, like motor, cognition, language. And one of them is adaptive, which is the self-care, or the ADL skills. And it's performed by both structured, where you might observe the child performing the task, or an unstructured, where you're asking the parents questions about whether or not their child can or cannot perform a particular task. There's another tool that's called the Child Occupation Self-Assessment, and this is a checklist where the child rates what problems they may have and how big a deal or how important that is to them. So I think it's important to know whether or not this is would give you information on that top down, so that you know what the challenges are going to be in terms of working with the child, whether or not they're going to be willing to participate in the activities that you plan. Hawaii Early Learning Profiler Help is used both in observation and checklist. Observation means you'd watch the child perform the task. One of the things I like about it is that it's set up, it's got two sections. There's one for birth to 3 and then another one from 3 to 6. And it provides a curriculum for the teachers or the therapists to be able to progress the child. So it looks at what problems the child's having, helps it break down the task and then helps the teacher determine what activities might be beneficial to work on specific skills. And it's other things besides ADL. The Pediatric Evaluation of Disability Inventory is a parental questionnaire. It has 3 sections, one of which is ADL, another one's mobility, and another one's social functioning. Within that, it is you can administer it where you can compare children to their peers. So that's the norm referenced section. But it can also be used as a criterion reference measure, meaning that you're not going to compare that child. And I think this is real important for kids who have handicapping conditions, especially physical handicaps. They're probably never going to be comparable to other children their age. But a criterion does evaluate the child, and then say 6 months you do intervention, 6 months later evaluate or assess the child again, and you can compare their skills to what they were doing now as to where they were 6 months ago to determine if they had made progress. And it does it in a standardized way, so you can, whether or not intervention was beneficial or not, because sometimes children will improve or they'll make changes in their skills, but it has to do with maturation and not necessarily as a result of the intervention strategies that you worked on with the child. And then the last pediatric measure is the WIFM. The WIFM stands for, we meaning the pediatric part, and FEM is the functional independence measure, which we're going to talk about with the adults. That's like the gold standard in hospitals and rehab centers. WIFM is also going to be used in hospitals and rehab centers for children. Okay, so this is a list of different adult ADL measures or assessment tools that are used. And like I said, the FEM is the gold standard. The WIFM is, the category is the same, that's why I didn't go into it a second ago in the last slide. So the FEM is intended to measure disability, and as such is most useful for the description of disability or program evaluation. It looks at 18 items on a 7-point scale. It looks at motor, cognition, performance areas of self-care, sphincter control, mobility, locomotion, cognition, and socialization. And you will be learning that tool within this curriculum. The Klein-Bell evaluates basic ADLs, and it's broken down. It's a task analysis. So each task is a very simple step-by-step behavior items. Now, it's very long to administer and to break down, as you have begun to get the idea with task analysis or activity analysis. There's multiple steps that you have to look at. But I think it's very, so if you're in a kind of setting that you have enough time that you can do that, it's going to give you a lot of detailed information. And it would be done in a standardized way so you can determine whether or not your outcomes as a result of your intervention strategy. However, if you're in say an acute care setting, you may evaluate, you get a referral for a client on Wednesday and the patient's going to be discharged on Thursday. You're not going to have time to do this type of comprehensive assessment tool. So that might be, there's many factors of why you choose, and we'll get into that more as we learn about assessments. I just wanted to show you so that you had kind of an understanding or appreciation of assessment of ADL. The KELS is another tool that you will learn in this program, and it's administered through interview and direct observation. Looks at self-care, safety, health, money management, transportation, telephone, work, and leisure. The AMPS, or the Assessment of Motor and Processing Skills, has both a pediatric and adult, one's for peds and one's for adults, and it looks at both motor and process skills while during observation of a functional performance. It is a tool that you have to demonstrate your competence by becoming certified in order to administer the assessment tool. So you can't just go pick it up and read the manual and figure out how to administer it. So you'd have to go to a course and then establish your reliability to be able to accurately score the assessment. And the last one is another tool that you'll be learning this semester. It's called the Canadian Occupational Performance Measure, or the COPM. Structured interview. You would ask the client what they would like, what problems that they're having and what they would like to work on, and then they prioritize it. So that is a top-down approach that helps you get an idea of what the priorities are for that particular client. Or you could use it with parents to ask them what their priorities are in terms of, this is just the example of the Klein Bell that I mentioned earlier, and you can see this is the task of shaving, and you can see how these 6 categories, or 5 I guess, with specific items that you would check off whether or not they were able to or they were unable to. And this is an example of another ADL checklist that might be used. Sometimes therapists will, whereas the previous tool was a standardized tool, it's going to be performed in the same manner each time, and it has a little more credibility because it's been looked at in terms of reliability and validity. Just doing a checklist it's a good way for documentation, but it might not necessarily accept it as an appropriate outcome measure. But you can see with this, I know a very small print, but I just wanted to kind of give you an example. The top part here is the level of assistance, and we'll be talking about that here in a second. And then you have the categories, like this one's transfer, functional balance, bathing, and undressing. This column, this is like the first time you administer it, this is the second one, so you can determine whether or not the client has made progress by the level of assistance has maybe gone down, that they're more independent than they were previously. So after you have evaluated or you've assessed the client, you've determined the specific problems and the interest that the client has, then you can determine your treatment plan. Frequently, the 2 big things that you're going to work on are either remediation, and in a child you're going to be establishing the skills, or with an adult you're probably going to restoring. So they've had an insult of some sort, maybe it's an injury or they've had an illness, and you would then, the intervention strategies that you come up with would allow the individual to get back to or to restore their functions. So using a establish or restore remediation approach is more of a bottom-up, because you're looking at more the component deficits that an individual may have. So with that, in order to guide our intervention, we're going to utilize different frames of references to help figure out what strategies that you need to employ the client to be able to meet their goals. So it might be, for example, biomechanical. In a biomechanical approach, you might work on strengthening, range of motion, the body alignment of the individual. NDT is looks at usually is for individuals with neurological deficits. So you would look at muscle tone, you'd look at postural stability or core strength and stability, and then how the child or the adult even could move, or their mobility. And there's specific handling techniques that you would do that would inhibit abnormal patterns and facilitate normal patterns. With sensory integration, this looks at individuals who have sensory processing deficits, and you would determine what environmental factors are contributing to the person's inability to perform a particular task. And so if they can't button a button, is it because they don't have enough sensation, they can't feel the button, or maybe they're hyper reactive to the tactile touch, and so they don't want to touch the buttons with their fingers. They might do it with their palms, but they can't do it with fingers. Or it might be a perceptual motor issue. Does the individual have visual perception problems, figure ground, spatial relations? Can they discriminate what it is that they're looking at? So if you're not remediating to look at the specific components. Another major category, their problems are too complex, or maybe they're lifelong and they're most likely not going to succeed by doing it in the typical way that individuals perform the skill. So you would look at adapting or an alternative way for the client to be able to participate in what they want to do. Adaptive therapy refers to modifying the task, the method of accomplishing the task, or the environment to promote independence in occupational functioning. An example of modifying a task might be to switch from shoe tying. You might have the client wear slip-on shoes. Learning a dressing technique for individuals with loss of the use of one side of their body is another way of modifying the task. Installing grab bars in the bathroom to enable self-transfers, and storing often used items within easy reach are example of modifying the physical environment. Teaching a wheelchair user ways of interacting with non-disabled individuals so that he presents himself in a self-assured, capable person is an example of adapting the social environment. So depending on what the problem is or why the person can't participate, you'd still want to do a task analysis to figure out what area you would need to work on. Okay, this is just an example. I think this is in your Pedretti text. Maybe the individual needs to wear tie shoes. The shoes need to be supportive, or they can't afford to get another pair of shoes, and so you would modify this task as just one method that you can perform a one-handed shoe tying technique. If you have tennis shoes, you might try this sometime. This picture is one of a tub and bath chair. So the individual maybe could learn how to transfer from, say, their wheelchair to the tub bench and bring their feet over, and then they could maybe bathe themselves independently. This is a picture of a dressing stick that was used primarily, I would say, for lower extremity dressing. It's got a hook on the end where the person can help pull their socks on, pull their pants on. It's got a hook on the end that might be used for zippers, and a long handle that might also be used for hanging a hanger up or getting clothing down from the rack in their closet. This is a picture of a pot holder, and you can see, so it would be used for someone who only has the use of one hand. They can't stabilize the pot, which would be very unsafe if they just stirred without stabilizing the pot in some way. And these are just built-up handled spoons that might be used for individuals who have difficulty with grasp. This is an example of a home safety checklist. Sometimes individuals, not just only individuals who are in wheelchairs, but maybe those who have mobility problems, may be just even looking at universal design for elderly individuals. And these are ways that the environment could be modified to allow the person maybe to be able to stay in their own home and not have to go to, say, an assisted living facility. Okay, so to further my point of using frames of reference to guide your thinking, I want to give you an example of both some remediation and compensation strategies for the problem of buttoning with one hand. So the individuals had maybe a stroke, or maybe like an older adult, or it might be a child with cerebral palsy who has hemiplegia, which is one side of the body. Okay, so that's the problem. They can only use one hand. So if the approach is, with the child, a developmental sequence approach, the frame of reference I might use is a developmental. So I'd look at when is normal acquisition, where is the child at this level, what's the next step that they need to be in terms of motor or strengthening movement that would need to entail for the child to be able to, or even cognitive, to visual perception, lining up the buttons. For example, in therapy, what we would do would be work on fine motor skills of being able to grasp maybe a coin, even, because it's about the same width of a button, and putting coins in a piggy bank would be an example of an activity I might do that's working on the fine motor skill prior to actual working on the buttons. If the approach I was taking of one of reduced impairment, I might look at, well, what is the problem biomechanically? Does the person have decreased range of motion? They have a neurological problem, and they might have increased spasticity in their hand. They may have decreased tone in their trunk, postural control, to be able to sit up. What's the specific problem? If I'm using an NDT approach, it's a neural developmental treatment approach, I'm going to look at what can I do to increase the tone, to have them approximately to give better stability so the child can sit better. And then I might do frequently with a child with hemiplegia, or even somebody who's had a stroke, there might be increased tone or spasticity in the hand. So I would be maybe doing some weight-bearing tasks to allow for the hand to be open, and facilitation techniques to hand over hand, to guide the hands to be able to bring the shirt together. So you can kind of see how, or if it was a behavioral problem, if I looked at why the child's acting up, they don't want to perform the task because they deem that it's too challenging, the task is too challenging. So you might do some sort of behavior modification to get the child to perform the task. Okay? So now so those were all remediation types of techniques. For compensation, I might use human occupation as model of practice, and I would just teach one-handed buttoning. This is going to be more of a top-down approach. The client wants to participate in and be independent in their own dressing. Together, we've collaborated and determined that there's no reason to really work really hard on trying to get the motor skill necessary in the hand for the person to button a button like everybody else does. So we're just going to do one-handed buttoning. If I was using assistive technology, my frame of reference might be one of rehab or biomechanical or NDT, and so I would teach them how to use adaptive equipment such as a button hook, or I might sew the button on the buttonhole so it looks like it's buttoned, and then put Velcro on the shirt and the bottom underneath where the button is, and teach the person how to fasten their shirt so it looks like they have a regular shirt on. Or maybe the compensation strategy might be that the person doesn't want to mess with their own dressing. They're just going to have somebody else perform it for them. So they'd use a personal assistant. This technique would be facilitated or guided through the human occupation, or psychosocial coping strategies might be the frames of reference that are used, and the end result would be that someone else buttons the button. So the end result is the button gets buttoned, whether it's a remediation or a compensation strategy, but there's a variety of ways that you would go about getting that end result. In addition to intervention, or when you're thinking about intervention and assessment of the individual, there's a lot of other considerations that come into play, and this is part of your clinical reasoning skills. You need to become familiar with the client's culture and cultural values in relation to self-care, and say the sick role, or how much independence. For the individual whose culture does not value independence as highly as our Western culture does, the OT may focus primarily on teaching the client and family to adapt. Even if you think the condition, if that's not part of their culture, but through remediation techniques, if that's not part of their culture, then you're not going to push that on them. You also look at values of the client and his peer group when you're selecting the objectives and initial active ADL or IADLs. What is it and I think the COPM is a good example of finding out what the priorities are so that you know what to work on next. Looking at the demands of time and energy for balancing the activity throughout the client's day. The children I was telling you about that had spina bifida, for functional mobility, which is an ADL, when they were younger, many times they'd be fit with very elaborate bracing. There's a brace that's called the reciprocal gait orthosis, a long leg brace. that the child wears. I've worked in combination with the physical therapist. They're teaching them how to gait, but part of that is to be able to sit functionally. The child would have to learn how to unlock and lock the braces so they could pull up to standing using a walker to be able to walk across the room to get to the next activity. Well, it's a very laborious process. These children tend to have some weight issues. Their metabolism is lower than other individuals, and I think it's part of their condition. So as they get bigger, and so maybe as a younger child that was a high priority, but when they get a little bit older, they get from point A to point B. They could do it independently, even though they're wearing braces and they've learned how to unlock and lock the braces. But by the time they get there, they're so exhausted that they can't perform their schoolwork, or they're too tired to eat. Same thing for dressing. It may be that it takes them an hour and a half to independently dress during the day. They can do that, but at what cost? Eating is another example. I can remember working on all these therapeutic ideas, and I had the students come in and interview clients. You'll probably meet Timothy, one of my friends I've worked with for a long time, and he's very multiple challenges. Or interviewing the mom one time to determine, and they were asking how much time it took for her to feed him, and she counted up the amount of time, and she was spending 8 hours a day feeding him. Well, we made some adjustment what she was doing at that point, because I was asking way too much of her, and that was way too much time being spent on just the one occupation of feeding. The home environment. What's the environment the client will return to? They're in the hospital, or do they live alone? Do they have family members that are willing to help them? Do they have a roommate? Do they have the financial resources for assistance? The adaptive equipment that I showed you, we'll learn about later when we go to AccuCare, the difference between durable medical equipment and just adaptive equipment, of which the adaptive equipment, none of which is paid for by Medicare or insurance. And the durable medical equipment would be what resources that they have. You could probably make many people very independent, but if they don't have the financial resources, maybe they live on a second-story apartment that doesn't have an elevator, and they're in a wheelchair. You may have an electric wheelchair, but they don't have access to a van that can transport them. So making those kinds of choices, you have to take into these considerations when you're working with individuals. Okay. Another thing that we have to look at is the level of independence. And this is gold standard, or these definitions, something that you need to learn. It was determined by Medicare, and insurance then follows this. So when you're documenting, you're going to determine the level of assistance the individual has. Dependent or total assistant means that the patient needs 100% assistance of one or more people to perform the activities. This can also be motor, or it could be cognitive. For example, with cognitive, they might need cognitive stimulation to elicit a functional response, or external stimulation such as swallowing when food is placed, in order for the person to swallow when food is placed in their mouth. Max assistance means they can do some of it. They help with part of the task, but they need almost total assistance, anywhere between 75 and 99%. You can see Mod Assist is 50 to 74, men 25 to 49. And one of the things that's important, it is a judgment call to determine whether or not, this is 48% or 52%, because that makes a difference in terms of what category it is. I think it's important as a new therapist especially, is to, when you're first evaluating a person, to err on the side of documenting that they require more assistance than they do. Because once you say, and then also you have to be specific about what you're saying they have the level of assistance. If you say, they're independent in all ADLs, well, that means all those 9 categories. So they might be independent in feeding themselves, but they're not independent in getting in and out of the shower. But if you say they're independent in ADL, that's what you're signing off on, that all those 9 categories they can perform completely independent. With the level of assistance, it's probably better to say they need mod assistance rather than min assistance, because you want to make sure that you just maybe observe them one time, that they can do it in a number of ways. The standby assistance is usually done when the person needs supervision. It's usually for safety issues. They can perform all the tasks, but you're not really sure you want to walk away. They might have some judgment issues when they bend down. Maybe they're sitting on the side of the bed and they bend way over when they're reaching their shoes, and you want to just be there just to make sure they don't fall. Independent with setup means that the person can't gather all the supplies that they need. They may be a paraplegic. They can bathe themselves or shower themselves independently. They can get their wheelchair into the bathroom. They can take all their clothes off. They can transfer from the wheelchair to the tub bench, get their legs over, and they can, with the soap there and the shampoo, they can do all that independently. But they can't go gather the soap, the shampoo, the towel. They might not be able to turn on the faucet and get it the right temperature. So that would be the setup part of it. And then independent is just like you and I perform the task. All right, so we looked at sleep and how that is restorative in function. We've looked at ADLs, and now we're going to look at quiet focused activities. This is the last category of restoration. Our American culture tends to rush. We value productivity, and in treatment, in design, we have to include some sort of restorative aspect of occupation so that we can rebuild a satisfying and healthy patterns. Participation in meaningful leisure occupations is vital to a healthy, balanced lifestyle. Leisure time may be spent in a variety of ways indicative of an individual's unique interests. Examples of quiet, focused leisure occupations might include reading, doing arts and crafts, biking, hiking, fishing, cooking, yoga, going to concerts, watching movies. Any of those things are going to be restorative in nature. Because of the uniqueness of individuals, this list is very long, so it's important to, again, that client-centered and find out what activities provide them restorative in nature. What's restorative to one person might not. I don't particularly like to watch a lot of television. I do occasionally like to watch something to relax, but watching 2 or 3 shows are all evening long, I value productivity too much. That then is counterproductive for me. It doesn't allow me to relax. It just makes me more and more anxious because I can think about the list of things that I need to do. And the last topic I want to talk about is the spiritual activity. It's often through religion that individuals hope to reach a greater understanding of the spiritual self and gain a sense of something greater than themselves. However, religion is a way to reach the spiritual aspect of self, but spiritual experiences do not necessarily have to occur during religious occupations. Spirituality occurs as a result of engagement in occupations that take us away from ourselves, make us lose our sense of time, or give us a sense of connectiveness. Spiritual activities give us a sense of fulfillment through an occupation that was me. Okay, so that concludes our discussion or lecture about restoration, and I hope that you are able over this Labor Day weekend that you were able to balance your occupations with a little R&R.